everyone. This is Dr. Mark Riggs with 5280 Functional Medicine, and this is part 3 of how to prevent and treat type 2 diabetes with natural medicine. We've already gone over what type 2 diabetes is, how it happens, and major risk factors that predispose us to developing type 2 diabetes. And in this presentation, we're going to be going over how to test for type 2 diabetes. Typically, type 2 diabetes is tested for and monitored through a combination of blood chemistry analysis and potentially urinalysis, as well as several other methods of examination, which we will talk about. Functional medicine practitioners like myself are typically attempting to catch these chronic diseases well upstream before they ever occur. But if a patient comes in and they already have type 2 diabetes, testing and monitoring through laboratory analysis is essential in its continued management and reversal. I like to say, we test, we don't guess. It's extremely important that patients monitor their glucose levels throughout the day using a glucometer, and they will gather both fasting, first thing in the morning, glucose levels, as well as random glucose levels throughout the day at agreed upon intervals. We also like to know the patient's fasting insulin levels to determine how the pancreas is functioning. And we also may have patients perform regular urinalysis testing to measure glucose in the urine. I often run these tests on commercial motor vehicle drivers for their DOT physical exams. However, urinalysis is a good screening test. It's very inexpensive, it's easy, it's convenient, it's non-invasive, but there is a high rate of false negatives with urinalysis, meaning the patient may have type 2 diabetes and the urinalysis may not pick it up. We also like to know the patient's hemoglobin A1C level. This is an average of the patient's glucose levels over the past 3 to 4 months. Helps diagnose and monitor type 2 diabetes, and it is a test that patients can't cram for as opposed to the glucose measurements. And finally, we look at GSP, which is an average blood glucose over the past 2 to 3 weeks. So it's very helpful to have a random or fasting glucose level, which is like a snapshot in time, a GSP level, which is a 2 to 3 week average, and then a more long-term measurement like a hemoglobin A1C, which is a 3 to 4 month average, and combine all that information along with fasting insulin levels and other biomarkers in order to gather a very comprehensive picture of a patient's diabetic profile. Here's a chart that just demonstrates what exactly equals diabetes as far as a person's hemoglobin A1C levels or fasting glucose levels, as well as the pre-diabetic range and the normal range. I disagree with the normal range slightly, and so I've added them in at the bottom here. I like hemoglobin A1C to be between 4.7 to 5.4, ideally. I like fasting blood glucose in the 80s, ideally. If it's in the 90s, as a functional medicine practitioner, we view that as the beginning of insulin resistance, and then you hit 100 and you're at prediabetes. And fasting insulin, ideal would be 2 to 3, although that is often too much to ask for diabetics. But that is ideal. I like to remind my patients that these measurements are in a continuum with one another. They are not, it's not a light switch. Once you go from 6.4 to 6.5, it's not like you were fine at 6.4 and then all of a sudden 6.5 and now there's a problem, although conventional medicine often treats their patients that way. So for example, I've had numerous patients come into our office and tell me that, well, I went to my doctor over the past several years and I was fine, I was fine, I was fine until all of a sudden one day I wasn't fine. What happened all of a sudden? And upon inspecting their blood work over the past 3 to 5 years, I noticed that their glucose levels had been rising and their hemoglobin A1C levels had been rising slowly and steadily over those years, and their doctor never told them about it, which is very unfortunate because, again, as a functional medicine practitioner, I like to catch these things early, well upstream, there, so that we have plenty of room to deal with the problem, and the problem's easier to deal with when we catch it early. Simple diet and lifestyle changes can turn the ship back around. But once we are way out of bounds and the cart has derailed, then it's much more difficult to deal with. Other things we monitor for in our type 2 diabetic patients are things like blood pressure, and it's going back to those alarming statistics that I mentioned earlier in presentation one. Diabetics have extremely high rates of complications from cardiovascular related events, such as strokes and heart attacks. Okay, so we like to make sure that blood pressure is below 120/80. And I encourage my patients to keep an at-home electric blood pressure monitor so they can monitor themselves and calibrate it at their doctor's office at least yearly. And as far as blood pressure goes, I usually tell my patients this: check your blood pressure one time out of the month at about 5 or 6 different intervals throughout the day. That way you can find out what time of day your blood pressure is highest. And when you monitor yourself on a daily basis after that, you want to monitor yourself when you're at the time of day that your blood pressure is the highest. Because who cares when it's the lowest and you're at home and you're taking it easy and you're kicked back watching TV? Who cares if all day you're at work and or on your feet or going to the store and your blood pressure's through the roof? So we want to measure the blood pressure when it's the highest, and the only way we know that is to take one day and monitor our blood pressure at many times, many different intervals throughout the day, and then retest based on the highest measurement. Blood pressure is very, very important to get to know intimately. Here's another chart just demonstrating that the stages of hypertension or high blood pressure go up one level every 20 units on the top number, the systolic number, and every 10 units on the bottom number. So we start at 120/80, and then 140/90 is stage 1, 160/100 is stage 2, etc. And if you ever take your blood pressure and you're over 180/120, you need to get to your doctor's office ASAP. And if it's much higher than that, you need to dial 911 and admit yourself to the emergency room. Other things we monitor besides the typical metabolic biomarkers that I discussed in the beginning and blood pressure, we also want to monitor blood lipids, because abnormal cardiovascular disease markers are often the first sign of an individual who will go on to develop diabetes. And again, to reiterate, 55% of diabetic deaths are due to cardiovascular disease. So this is a big, big problem. Regular screening is absolutely critical. And this is because the nature of type 2 diabetes is that there is an excessive amount of blood sugar floating around in the blood vessels. And what that does is cause inflammation to the lining of the arteries, making us far more susceptible to cardiovascular related events like strokes, clotting, and plaquing. So we monitor our cardiovascular risk not by the standard lipid panel that's run on your yearly checkup that consists of cholesterol, HDL, LDL, and triglycerides, but we monitor it with all the other biomarkers that I have listed here. And this is really important because recent statistics demonstrate that patients with perfect levels of cholesterol, HDL, LDL, and triglycerides, up to 50% of them will continue to go on and suffer from a cardiovascular related event like a heart attack or stroke. And so if you really think about that, that's quite frightening because it means that the basic lipid panel test is only 50% effective for correctly assessing our cardiovascular risk. And if something is only 50% effective, that is not a very good test. So we can increase our likelihood of identifying potential disastrous cardiovascular related issues by measuring all of these biomarkers listed here. And it starts with a lipid fractionation that includes the basic lipid profile, but subfractionates LDL and HDL particles, looking for the smallest, densest forms of LDL that are the most harmful forms. Same thing with HDL. We look at inflammatory markers like high sensitivity CRP, that's very telling for our inflammation of our coronary arteries. Homocysteine is a byproduct of folate metabolism, and when homocysteine builds up, that is another independent vascular inflammation biomarker. Fibrinogen is another inflammatory biomarker. Lipoprotein A is arguably the most telling vascular inflammation biomarker. It is 10 times more dangerous than small, dense LDLs, according to the literature. And ferritin and ESR are additional inflammatory biomarkers. And we run all of them because they all measure our inflammation from different angles, so to speak. So we like to gather a comprehensive picture. The bottom line is the basic lipid panel, cholesterol, HDL, LDL, and triglycerides, that doesn't tell us much at all. But it doesn't stop conventional medicine from continuing to run it and to run it only, just because that is the standard of care. And as I've mentioned before, the standard of care in the United States is severely deficient. Other things we like to check routinely in our diabetic patients are their eyes, their feet, and their kidneys. Going back to that statistic that I rattled off in part 1, that type 2 diabetes is the leading cause of diabetic retinopathy and blindness, of limb amputation, and renal dialysis. So we are looking in patients' eyes, doing regular ophthalmic exams, checking to see if we see any hemorrhaging of the retinas. We're checking in between the webs of their toes and the bottoms of their feet to look for sores that could become ulcers, that could develop gangrene and lead to an amputation. And we're also running regular comprehensive metabolic profiles or comprehensive metabolic panels to measure kidney function with BUN, creatinine, and EGFR, just to make sure that the kidneys are functioning well and that the excessive amounts of blood sugar aren't trashing the kidneys. So after everything we've discussed about testing for type 2 diabetes and monitoring type 2 diabetes, it's all just to say that the bottom line is that even though medical textbooks tell us that type 2 diabetes is chronic and progressive and irreversible and therefore incurable and can only be managed with pharmaceutical drugs, this has been proven by functional medicine practitioners all over the world to be absolutely false. It is true that it is chronic and progressive and irreversible with pharmaceutical drugs alone. But using a functional medicine approach, the vast majority of cases of type 2 diabetes are treatable and reversible with dietary and lifestyle modifications alone. But one of the biggest problems that we face is that our food industry could care less about the health of the people in the United States, and our healthcare industry, astoundingly, almost never discusses diet and lifestyle. And this is a massive, massive problem, and what I would say is one of the biggest contributors to the reason why type 2 diabetes is the fastest growing chronic metabolic disorder in the United States. Next, in part 4, I'm going to discuss the conventional medical approach to treating type 2 diabetes. Thanks for listening.